Hello everyone, and thanks for joining us today for the second Blue Alliance Value-Based Care webinar. My name is Jason Lotzer, and I'd like to welcome you all on behalf of Blue Cross Blue Shield of North Dakota. A few housekeeping items before we get started. Everybody will be on mute during the webinar, but you'll be able to ask questions at any time. So if you look at the GoToWebinar panel, you'll see a tab where you can type your questions, and at the end of the presentation, we'll answer as many as possible. Just a note, we'll only be answering questions related to the agenda topics we're covering today. Before we get started, I'm going to introduce Pat Belmore, the Senior Vice President and Chief Marketing Officer, to say a few words before we begin. Are you there, Pat?
Thanks, Jason. On behalf of the entire executive team here at Blue Cross Blue Shield, I would like to welcome and thank you for making the investment in being here today. Today we're here to talk about Blue Alliance. Blue Alliance is really a partnership between you as our client, Blue Cross Blue Shield of North Dakota, as well as the healthcare systems throughout the state of North Dakota. This is a fundamental change in healthcare financing, one that slows inflation and improves health outcomes. Value-based care philosophy and methodology have been phased in over the past decade with active participation for providers here in North Dakota. Additionally, we have seen a dramatic increase in value-based programs throughout the entire United States. Blue Cross Blue Shield of North Dakota does recognize that we could have done a better job in communicating with you about this program. So, thanks for your feedback. As a result of your input, we're committed to better communication, including things like what we're doing today, and individual consultations, which you can certainly request from your sales representative. Also, we are continuing to enhance Blue Alliance in terms of quality accountability and, on the client side, clearer contracts and improved reports. The team will now take you through some of the reporting. Jason, do you want to kick us off?
Thanks for that introduction, Pat. For the agenda items today, we're going to be covering provider perspective, Blue Alliance reporting, financing value-based care, the path forward, and questions and answers will be at the end. So I'd like to introduce my fellow panelists who will be presenting today. Dr. Greg Glassner, the Chief Medical Officer, Chelsea Metter, the Director of Provider Engagement, and last, Mike Carlson, the Director of Employer Consulting and Wellness Services. Thanks again for joining us today and your continued trust. You can get us started, Dr. Glasner.
Hello, and thanks for having me on the webinar today. I'm Dr. Greg Glassner, Chief Medical Officer at Blue Cross and Blue Shield of North Dakota. I've been asked to give a few words on the provider perspective of Blue Alliance. I think I'm qualified to do this because just 8 months ago I was on the provider side of the equation and participated in the Blue Alliance program. So let's just step back a second and set the stage. All providers feel that they provide good care. It's what they're trained to do. If they think they're doing something wrong, they will change their practice, because all providers, come to the table every day to provide good quality of care. The problem is, providers don't know what they don't know, particularly when it comes to quality outcomes and quality scorecards. For instance, they don't know if a patient got their colonoscopy, even if they ordered it. They don't know if somebody had a mammogram. They don't know if somebody stopped to get their labs after their visit. So I think one of the ways that we can improve care is by helping providers, by giving them a quality scorecard like the Blue Alliance program. Now, many of the large provider groups still have internal quality scorecards. They work very hard at achieving the goals of that. And I think the large groups sometimes do better because they have more resources on the backside of the equation, people who can work the case lists and the quality lists. And it's not that the small provider groups don't have the same intention of providing good quality of care, they just sometimes don't have the resources. That's where something like the Blue Alliance program comes into play. Well, we actually can track the quality measures, give feedback to those providers so that they can improve the quality of their members. The Blue Alliance program, which is a value-based care program, helps track a number of quality measures that just are kind of randomly selected, but they're not that randomly selected. Their quality measures are selected where we can try to get the best value to the members. And in the end of the day, the best value for the members means better care. and it reduces costs to the members. Now, these measures are reported regularly to the providers, along with some other information like in migration, out migration of their patients. But then it also gives providers feedback on where they need to focus their efforts to improve quality. Most providers are generally very responsive to quality scorecards. Everybody wants to be the top provider. None of them want to be the lowest quality score provider. So by giving the scorecards, it motivates providers to do the right thing for their patients. Sometimes they just don't know which patients need or which areas they need to focus on, such as interim rods for diabetes and hypertension, how many members don't have good blood pressure control. If we can get providers to do that, good blood pressure control, if you can alleviate one stroke, you're providing good outcomes to the members, and that reduces costs overall. So the momentum is building on value-based programs. I think if you look across the country, over 50% of the Blue Cross plans have a value-based program that are tied to their fee increases. The BlueAlliance program was really reinvigorated in 2016, and then we had version 1, and now we're on version 2. So looking forward, we're trying to look at fee increases tied to value-based initiatives. In other words, value for that fee increase, and so the members actually get value for what they're paying for. And it does pay dividends, as you'll see further on in the presentation. So this program has been updated. We update the quality metrics where we think that we can get the most good for the members, and we can look at where the cost trends are to the management, and then try to get what I call the biggest bang for the buck for the members, which also improves their healthcare quality of life long term. Provider participation of the BlueAlliance program is excellent. Today, over 90% of the providers in the state of North Dakota are participating in the BlueAlliance program. There are 3 levels of engagement that the providers can participate in. The first one is the patient-centered medical home. That's the base layer where you participate in the quality program, where you report your quality measures, and if you achieve certain thresholds, then you get a value-based payment for that. The second level is the shared savings model, where there's upside risk only for providers. In other words, if they hit higher quality targets than the base layer, then they save money in the overall cost trend. That savings is shared by the providers get a portion of that, and part of that goes back to Blue Cross, which is reflected in lowering your premiums down the road. The third one is the risk-sharing model, and that takes a really mature quality program to really move into that model. There's upside and downside risks. If the providers don't provide good quality of care, then they can pay a penalty in terms of they have to pay back into the program if they're not improving the quality of the care to the members, to the jury that's agreed to along in the program. They also, however, have a chance to get a higher reimbursement if their quality scores are higher than the base model. So they get increased saving, increased value payments for risk taking, but they also have a downside risk in the risk sharing model. So really, what's the end result of the BlueAlliance? The BlueAlliance results improves quality of the members' lives, and it also saves money. If you look at the last 3 years program, the cost curve is 3.5% to 4.5% less than the expected trend. Now, that doesn't sound a lot, but when you tie that to dollars, per attributed member per month, that's $17 to $23 savings per member per month going forward. That turns out to be real dollars when you roll that out over time. So by participating in the BlueAlliance program, it improves the members' quality of life, and it also saves money. So we're going to continue this program because we think it's got value, and value-based medicine is the way of the future, not volume-based medicine. So I think if you really look at the results, they're quite positive. And the further we can develop this and the further we can engage members into this along with providers, it'll be a reward for both parties. With that, I'm going to move this on to Chelsea to explain some of the fine details of the program. So I'll take it away, Chelsea.
Thank you, Dr. Glasner. Next, we're going to talk a little bit about reporting and employer group specific reporting with regards to BlueAlliance and what you can expect from us in the future. One of the foundational elements of the Blue Alliance program is whether or not a member has a primary care provider. So on the report, we break it down to see in the blue category, those are the number of your employees or our members that have a primary care provider that is part of the Blue Alliance program. In the green, you can see the number of members or employees that have a primary care provider, but they're not part of Blue Alliance. And then in the orange, you can see how many members or your employees are considered unattributed. So when they're unattributed, they may very well be using healthcare services, but they don't have a primary care provider, which is certainly very important. The next part of the report is just the age distribution of those that are part of the Blue Alliance program, those that have a primary care provider that's not part of Blue Alliance, and then again, those that are unattributed. So as you would suspect, a lot of young adults fall into the unattributed category, meaning that they don't have a primary care provider. And so just again, a breakdown of the age brackets that of your populations and who has a primary care provider versus who doesn't. Also on the report, you can see exactly where your employees are going and who they're attributed to. So you can see not only the provider, but also that provider's quality performance on the very left-hand side of this particular slide. And on the right-hand side, you can see exactly how much is being paid to each of those providers for both care management as well as shared savings payments. So again, these are things that are going directly back to the provider for the care coordination that they're delivering to your employees. So keep in mind, these are the top 15 providers, so it's very possible that you have some folks that are attributed to providers that fall off of the top 15, but this should give you a pretty good indication of the dollars and which providers they're going to, and of course, the quality performance of those particular providers. You also can see the estimated net savings specific to your employer group on the report. So that estimated net savings is a per attributed member per month calculation. So you can see that will differ from the net savings range that we discussed in the first webinar, which is anywhere from $17 to $23 per attributed member per month. So your employer group specific estimated net savings should fall somewhere around that range, although it could vary. Also on the report on the right-hand side of this slide is just the distribution of where your members reside that happen to be part of the Blue Alliance program. So just wanted to show you exactly where folks are living that are attributed to a primary care provider. We also look at what health segments your employees fall into and whether or not they have a primary care provider. We feel it's very important for everyone to have a primary care provider, whether you're healthy or you have moderate to multiple chronic diseases that you're dealing with. So when we look at this particular graph, you can see on the far left those that have a Blue Alliance and primary care provider, but then on the right hand side, that's your unattributed bucket. And for the most part, you're going to see mostly non-users and healthy folks in that bucket, but you can also see that there's a fair amount of minor chronic, moderate chronic, folks that have chronic diseases that don't have a primary care provider. And that is of concern to us and something that we look at on a regular basis to try and assess if these folks need a primary care provider. Maybe they're only seeing a specialist. That could very well be the case, but we still feel it's important to have that primary care provider presence. So this will be specific to your employer group and show you exactly where folks are falling within each of the health segments. We also want to look at utilization specific to your employer group. So one of the ways that we do that is we look at inpatient admissions on a per thousand per year basis, and we look at actual versus expected, and we get a % difference from expected. So in this particular case, the more negative the number, the better. So what we typically see, and this will be specific to each one of you, but what we typically see is what's showing up here on the screen, and this is across all of our self-funded groups. So you see those that have a Blue Alliance provider, they have about 18% lower than expected inpatient admissions compared to unattributed bucket, that orange bar, that's just under 1% below expected. So a lot less utilization from an inpatient perspective for those that have a primary care provider. We also look at it in an outpatient emergency room visit perspective, and that's also on a per thousand per year basis. You can see the BlueAlliance participating providers on average almost 18% below expected on that metric as well. The unattributed folks also are below expected, but not nearly as much as the BlueAlliance folks. And again, this can vary from employer to employer. The smaller employer groups are going to see a little bit more variation in this, but typically this is what we see. The BlueAlliance folks greatly outperform most of the other two categories. So again, this will be specific to your group, but you should see something very similar to this. If you don't, it could be a small sample size, and then also one of the other pieces you'd want to consider is, have you improved over time as a result? One of the other things that we can look at is potentially preventable events. So whether it's inpatient admissions or ER visits, these are things that could potentially be preventable. So think about the ear infection that goes to the ER, the asthma attack that ends up as an inpatient admission, things of that nature that if they were managed on the outpatient side, maybe wouldn't have to end up in a higher level setting. So these percentages are quite small, and again, these will vary by your employer group and the size of your employer group. But typically, again, what we see is the BlueAlliance folks continue to outperform those in the other categories. So again, very small percentages, so we tend to focus on the overall utilization, but wanted to show you this view as well because it also tells part of the story with regards to potentially preventable events and trying to manage things on the outpatient side. So we hope that you found the reporting valuable, and really what we're trying to provide is the foundation. And so if you have feedback on that particular report and other components that you would like to see, we would love to hear it. But it's all about financing healthcare in a different way. And so some of the metrics that we looked at are also the metrics that we measure providers' performance on. So potentially preventable ER and hospital admissions are some of the components of how we are going to finance healthcare in the future. So thinking about how do we achieve good outcomes, not just do more services. So we're going to go through a couple of the slides that we went through in the first webinar, just again as a refresher, go through some of the math, and then talk about what's yet to come in 2020. So again, as we talked about last time, there's two different types of provider payments. So you have the care management payments and you have the shared savings payments. So care management are for things just like basic foundational care coordination activities. It's paid to all primary care providers at all levels of the program, so 1, 2, and 3, and it's adjusted for their quality rating. Also this year in the program year 2020, so BlueAlliance 2.0, we also are making that risk adjusted. So what we know is that it takes less resources to take care of healthy folks than it does of folks with chronic diseases. So we're going to weight the payments accordingly, but typically the care management payments are far less than the shared savings payments, although that can shift depending on how providers perform on the financial side of things. So shared savings payments are, the math that we did last time in the last webinar, where we showed actual costs compared to those risk-adjusted cost targets. So how well they beat that target, we share in a percentage of that. Those are also adjusted for patient risk and provider quality rating as well. So as we talk about BlueAlliance 2020, so that again is kind of our new program year. So the prior shared savings payments that we put the pause on, we also are into a brand new contracting cycle with the provider community. So what that means is care management payments were intended to be made monthly throughout the year of 2020, and you can expect an estimated average about $3.78 per member per month. Again, that varies depending on the risk of the patient, so that's the average. And what we do expect is to issue those payments to providers throughout the rest of the year. So starting in September through the end of December, we want to make sure that we get those care management payments distributed to the providers. We should have been paying them every month for this particular program. We put that on pause to make sure that we could have conversations with you all and bring you along on this journey. Again, trying to change the way that we finance healthcare overall. We also have shared savings payments. So again, these are typically twice per year. They have been since we started the first version of BlueAlliance. There are some COVID implications. So with the COVID pandemic, there's been certainly a decrease in utilization, which makes it look like there's a lot of shared savings, so artificially low. So we're watching that. And we do estimate doing a payment to the providers, a conservative payment in November, which would be their typical interim payment for shared savings distribution. Again, we don't know what will happen through the rest of this year, if utilization will go back up and things will even out. So if we make that payment in November, it's going to be very much on the conservative side, and we want to make sure that we give you plenty of lead time so you know what to expect as well. I also want to reiterate what we talked about on the last webinar, because I think it's a very important point. So what we're trying to do is shift those dollars. So I wouldn't think about this BlueAlliance program and the shared savings pieces as new money. I think of it as shifting the dollars. So dollars that normally would have gone into a standard fee scheduling increase, which really creates that volume incentive, we're shifting those dollars away from that and into a shared savings bucket, which providers only achieve if they earn and earn it, but also they have to perform and achieve those outcomes for their patients and your employees and our members in order to gain that. And so it's much more appropriate. You can think about it as almost like a merit increase versus just a straight cost of living increase for everybody. So if you have those types of arrangements within your organization and you just give everybody a 2% raise every year, this is really moving towards, did you earn that 2%, or did you earn 4%, or maybe you didn't earn anything at all? So that's really what we're trying to shift to when it comes to financing healthcare, is paying for good outcomes, not just incentivizing that volume piece. I want to take some time to walk through the shared savings illustration again. We covered it in the first webinar, but we've gotten a few questions on this one, so I thought we'd just walk through it. So in this particular example, we have 20,000 attributed members to provider ABC. And the expected cost target, we expect those 20,000 members to cost $534.64 per attributed member per month. And so when we think about why are those folks going to cost that much, what we're doing is we're looking at not only the illness burden of that population, but their historical utilization of healthcare services. So how frequently are they in the ER? What kind of disease states do they have? What do we see from folks that have that disease states? How much do folks with a certain chronic disease, whether it's diabetes or asthma or whatever, how much do we see them utilizing the healthcare system? That all gets factored into that number, and that number changes every month because we have folks that maybe had an acute situation that now are better, or we have folks that had a chronic disease now that have developed another chronic disease or some other type of health complication. So that number is going to adjust given how the population behaves underneath. And so then we compare that to the actual cost. So what did we actually see for claims coming through for those 20,000 members? And then we'll take that expected minus the actual, and that will be the savings pool. It's very possible that you wouldn't see any shared savings in this. So meaning they were either, exactly at expected cost, or in some cases they might be above expected cost, which we certainly don't want to have happen, but it could. And for those providers that are participating in a level 3 arrangement, that means that they would owe you as the employer money back because they were not providing or coordinating those folks' care. And so it resulted in a higher than expected cost overall. So they would pay you back money. But in this particular example, they achieved savings. So that $47.24 is the savings pool. Now we're going to share a portion of that back, and that's dependent on quality. So the things that we measure within quality, there's a whole host of things, but some of the heavily weighted items are potentially preventable ER visits and potentially preventable hospital admissions. So things that, if you were managing in the outpatient setting, would keep you out of the hospital, high cost setting, and should result in overall lower cost. And so we're going to share a portion of that back, and then the rest is employer group shared savings. So, and wanted to walk you through the math again. We've got lots of questions on how exactly this works. I think the important thing to remember is this is all based on a population, and this population is attributed to a provider, and it fluctuates from month to month. And so your employer group population is part of the provider's population, but you'll have folks spread amongst many different providers who have different performance, which is why you see different payment amounts going to different providers as we provided in the report.
Thank you, Chelsea. This is Mike Carlson. I'm the Director of Employer Consulting and Wellness at Blue Cross Blue Shield North Dakota. We have been changing how we pay for services. So we're going from fee-for-service to a value-based program. Traditionally, our fee-for-service approach has been rewarding for volume and not value. There could be a lack of accountability and coordination, and it's focused on sick care. Versus our BlueAlliance program, which is our value-based program. It's aligning reimbursement with outcomes. Providers are empowered with data, because data is first and foremost on how providers work. It's focused on overall health from a population health perspective, and it invests in improving the health of our population. And we're not alone, right? All of our other Blue plans, brothers and sisters across the country are participating in these. So we have over 370,000 providers are participating. 70% of Blue Cross Blue Shield members across the country have access to value-based care providers. We believe there's a large savings through independent studies of over $146 billion tied to value-based care. And we have more than 3 times the value-based programs in place in front of our clients. That reduces our national overall cost trend by 35% since 2016. So, the first rule of healthcare is that it has to be local. So every program is going to be different. As you can see on the slide, there can be all kinds of different programs across the country. So if you have members in Arizona or California or New York, there's a value-based program in place for them to participate in. So the next steps are, our promise is to over-communicate BlueAlliance programs moving forward. So this will be our second WebEx, I believe, that we've had on this topic. So we plan to do these on a quarterly basis. We again appreciate your attention to this today. And if you have specific questions, we ask that you reach out to our account managers so that they can engage with you. We have specific reporting. If your population size is appropriate enough, we can provide reporting on it. And we just promise to do ongoing communication. With that, I'll turn it back over to Jason.
Thanks, Mike, and I'd like to thank Pat, Dr. Glasner, Chelsea, and Mike all for those great presentations and shedding a little more light on BlueAlliance. And thank you all again for joining us today. For those of you that haven't asked a question or would like to ask a question, just know that in the questions panel there in the GoToWebinar, you can type your questions in there, and we've got a few that have already come in. So we're going to get to as many of these as possible as we go through this. So I encourage you. We have Pat, Dr. Glasner, Chelsea, Chris, and Mike here available for questions live. So please, I encourage you all to ask those questions. I'm going to do a quick sound check here again, just to make sure that we have everybody. Pat, are you there? And maybe I'll go with Chelsea. Are you there?
I'm here.
Hi, Chelsea. And Chris, do I have you as well?
Yes, I'm here.
Okay. And then we have Dr. Glasner and Pat Belmore as well. And Dr. Greg, are you there?
Here.
Hi, Dr. Greg.
I am here.
Okay, great. So I'm going to go ahead and get started with the Q&A portion of this. Like I said, we've got a few that come in. I encourage the rest of you to ask questions if you want. Just type those in and we'll get to them in the order that they came in. So the first question here is for Chris. When did you first tell employees about BlueAlliance?
Well, thanks, Jason. We introduced the program in July of 2016 after our previous program, MediQ Home, ended, and we provided brochures and hopefully further explained that program. We've even offered now to have provider contracting team come and meet to discuss with our clients. So, again, let us know if you have that desire. Thank you.
Great, thanks, Chris. Chelsea, the next question is for you. Why did the billing change on BlueAlliance?
Yeah, it's a good question, Jason. And I think previously we handled the payments to providers through the claim system. So you would have seen these come through as individual claims for each of your employees. However, we switched last fall to a kind of a line item, and it's an aggregate charge back. And moving forward, what you're going to see is a nice invoice that kind of details out the charges by individual. And so we're moving this direction because it allows us to automate the process and make more timely payments moving forward. So we had a little bit of an interim period where we were doing manual payouts, but moving forward, we'll have a nicely laid out invoice tied to that.
Great, thank you, Chelsea. Dr. Glasner, I have a question here for you. So they ask, seems like another way for Blue Cross Blue Shield North Dakota providers to get more money. What do we get?
Well, first of all, I think you get value for the money, and I think you get better health outcomes. And that's really what we're trying to drive for, is really driving towards better outcomes, not more visits, more value, not more volume and more tests. We want value. We want tests that improve the long-term outcome, because it lowers your healthcare costs, but ultimately improves your health long-term. It's been shown time and time again, and the whole country is moving this direction. I think the country is tired of the cost of healthcare. It's not more money, it's actually less money overall.
Great, thanks, Dr. Greg. Chris, I have a question here for you. We've never paid this much in the past. Why are these BlueAlliance fees so high this year?
Well, the shared savings throughout the first 3 years of the program did steadily increase because providers continued to perform well. And we did continue to challenge providers throughout the program by adjusting quality goals each year. So that would help answer some of that question there.
Great. Pat, do we have you on the?
Yes, I'm here.
I have a question for you. This person asked, can we opt out of BlueAlliance?
Okay, well, thanks for the question. Actually, no, that's not going to be something to be permitted. I know Dan Conrad, who's our Chief Executive Officer, has kind of talked about this in prior communications. But really, BlueAlliance is a value-based payment arrangement, as we've talked about. It's proving itself to be really the best path to de-escalate healthcare costs, and others have kind of spoken about this also. It's really a critical part of Blue Cross's provider payment strategy. We need everyone on board to reach its full potential. Thanks, Jason.
Great, thanks, Pat. Chelsea, I have a question for you here. What is the ROI for BlueAlliance?
Good question. So Dr. Greg covered some of this in his portion of the presentation. So that $17 to $23 per attributed member per month. And then we also provide estimated based on your group. And so that number was calculated by an outside actuarial firm, Milliman. Many of you may have heard of them. And really what they're doing is they're taking into account all payments made to providers and the illness burden of a population over time. So what Milliman more specifically did is they reviewed claim trends for two populations, those within the BlueAlliance program and those outside of the BlueAlliance program. And so they followed that for a number of years and did so on a risk-adjusted basis because you want to even out those populations and make sure that you're comparing apples to apples. And what they saw is those within the BlueAlliance population, their claim costs increased at a significantly lower rate than the members that were not part of BlueAlliance. So that is strong evidence to suggest that we're generating savings by really dampening that claims trend overall. And so Milliman did the overall piece of that $17 to $23 piece. And then we specifically break out each employer to look at what we estimate your savings to be, again, looking at the BlueAlliance membership versus non-BlueAlliance membership over a number of years.
Great, thanks
Good
for
question.
the insights. Great insights, Chelsea. Chris, this next question is for you. How is the program being communicated to our employees so that we can see the positive effects of BlueAlliance?
Thanks, Jason. Yeah, good question. Through our employee wellness initiatives, we support the underlying components of the BlueAlliance program, specifically the importance of having a primary care physician. And you can actually sign up for our monthly wellness updates for free on our website. We can help you with that. I think we're going to actually plan to include some of that information and some links to where you can get that information in our thank you email back to you for joining the call today. So while we don't directly mention BlueAlliance, we do offer many educational opportunities that support the program. And again, hopefully those will be included in our thank you email to you. Thanks, Jason.
Great, thanks, Chris. Chelsea, we have a question for you. How will payments work going forward?
Yeah, so I mentioned in the slides kind of the new BlueAlliance 2.0 program that started here in 2020. So we're in the first year of a 3-year contract cycle. So with the first year, almost halfway complete, we've moved care management payments to monthly. And so I had shared that those will start in September. So when they start in September, that will be when the payments are made to providers. They likely won't show up on your statements until October, which pushes the timeline out a little bit. So I think on the slide I said September through the end of December. We're looking at the October, and we won't finish it up until probably February of 2021 to get caught up. And so as we moved into this new program and distributing payments on a more frequent basis so that it's more predictable, we'll have to have a catch-up period here. But I think the important component to remember is care management is typically the smaller amount. This is for kind of the care coordination activities that are happening behind the scenes, things that we don't directly reimburse for, but are very important to coordinating the care of individuals. So thinking about all the work that the nurses and the administrative staff do in an office and to keep folks out of higher level settings. So we're also risk adjusting those particular payments. So keep in mind that average that I shared, I think it was $3 or so, and that will vary depending on the illness burden of that patient, because we know that folks that have multiple chronic diseases take more effort to coordinate their care than those that are healthy. So you can see that payment will be adjusted accordingly. The other piece that we talked about briefly in the slides too was shared savings, and it's a little bit more complicated because of COVID, and we talked about the first payment being this fall and being a little bit more on the conservative side, but What we do want to do is offer you a schedule so that you can see when these payments will be going through to providers and ultimately back to you. But there is some time in between when we pay the providers and when it comes back as a charge to you all. So that will be part of some of our follow-up communication to you as we move forward.
Great, thanks, Chelsea. Chris, I have a question or two here regarding reports, and the first one is just simply, are reports available?
Oh, yes, they are. And some of our Blue Cross reps have actually distributed them to clients. And if you haven't received one, definitely let your account rep know, and we'll get that out to you as quickly as possible. And if you see something if there's something you'd like to see added to that report, let us know so that we can bring that back and add maybe to everybody's report, because a lot of times good ideas come from those who review the reports. So thank you.
I have another question that kind of dovetails into that, Chris. What is the appropriate employer size needed for reports, or are they available to all?
Yeah, good question. And I think we should have a report for every one of our self-funded clients. So we should have that for you, ready and waiting. I actually have the drive ready for people to pluck them from and get them out to you, the self-funded client. So thanks, Jason.
Yeah, and could you just go over that again, how, if somebody wanted a report, how they'd go about getting one, Chris?
Certainly, yes. Just reach out to your Blue Cross Blue Shield rep. If you know who I am and you have my email, send me an email. So I'll make sure we get your rep in touch with you along with your report, and then we can even help walk through that, similar to what Chelsea did on the presentation today. Thanks, Jason.
Yeah, thanks for that, Chris. This next question is for Chelsea. And this goes back to one slide that you had for BlueAlliance versus non-BlueAlliance, and the unattributed distribution graph that you shared, Chelsea. How does an employee or a member know which category their doctor falls into?
So that's a look at where the members fall. So doctors would be, so those that are in the BlueAlliance versus non-BlueAlliance. I'm struggling with the question a little bit because it's a member-focused report, but I think that, those within the BlueAlliance program would know if they're in the BlueAlliance program or if their organization is within the program, and we can provide a list of who's all in the BlueAlliance program. But as I think Dr. Greg mentioned, there's over 90% of primary care providers in the program. So the vast majority are. Those non-BlueAlliance providers are fairly far and few in between, but they should know that piece. But yeah. I would be happy to clarify too if I'm not answering the question super well.
Right, and I think that slide that was shown was more member focused, correct? Where the members fell versus the providers themselves. So, so this next question, Chelsea, maybe I think any of you can answer this, but you're on a roll, Chelsea. So they say that I missed the first webinar, so maybe this is clear in the first one. But what exactly is the purpose overall? Is it promotion of routine wellness visits versus waiting last minute with issues?
Well, it's a good question. So I'll get us started, and then Dr. Greg will be on to add in on this one too. I think the ultimate goal is to pay for healthcare differently to drive value versus just volume. So when we think about how we've traditionally paid for healthcare, you get a service, you get paid. You do a service, you get paid. That really creates an incentive for folks to do more, which doesn't always mean better care. And so if we want to shift the paradigm, if you will, in a different direction, we have to move the dollars in a way that incentivizes good outcomes and not just how many things you can order. So a lot of, what we've found over the years, and, Medicare's looked at this, many other states and commercial payers have looked at this, but there's a lot of waste in the healthcare system, and it's largely driven by the fact that the more that you do, the more you get paid. And so we need to shift that model and pay for care differently. And if you achieve good outcomes, then you get paid better versus just ordering more. So that's really the ultimate goal with this, but also making sure that we still maintain quality as we move along. So we don't want folks just to cut services to cut costs. We want them to achieve good outcomes. And so if it takes 5 tests, it takes 5 tests to have a good outcome. But what we're trying to avoid is maybe the 6th, 7th, and 8th test that isn't really adding any value to the equation. So that's the ultimate goal. But I don't know, Dr. Gregg, if you have anything else to add on to that.
Well, Chelsea, I think that was a very good answer because it's true. And, I mentioned earlier that some of the health systems have internal quality scorecards because they know that this adds value and they know that this is going to be the wave of the future. So they're trying to incentivize their providers, all their providers, to, when I say doctors, nurses, med levels, they're trying to incentivize those providers to do the right thing, to do the appropriate thing at the right cost, because healthcare facilities understand that the healthcare cost trend is unsustainable. So how can they add value back to the equation by providing value-based outcomes? And so the health systems will do this themselves and they do that with all their payers, not just with Blue Cross payers. So their scorecards will be a little different than the Blue Cross scorecard, yet it's all trying to achieve the same end, provide good quality outcomes at the most affordable cost, because the healthcare cost trend is unsustainable. So I think that we're all in this together and that we're trying to drive value and get better outcomes for long-term health benefits.
Thank you, Dr. Glasner and Chelsea, for that. Again, I'm going to, put it out there that if anybody wants to ask any questions, please type them in the questions panel and we'll get to them. We're about through most of the questions, so if you do have one, please ask it now, because when we get through all these, we will be ending the webinar. So I do have one more question here, and I'm going to start with Chelsea on this one, and if anybody else wants to chime in, that would be great. Since providers are getting direct payments for their increase in quality care, are their individual comp models adjusted?
It's a good question, and it goes back to kind of what we're talking about. So when you live in a fee-for-service world and you make more money by doing more, that's how the physician comp model is kind of evolved into kind of a volume-driven world. Because ultimately the health system will make more the more things that you do under a fee-for-service arrangement. So there's a lot of changes in the comp models within, the physician comp models now to focus more on quality, as Dr. Gregg was just mentioning, looking at quality scorecards and tying some of their compensation to that. You're going to see a bigger shift the more that we shift to value. So, right now we still have fee-for-service payments. We see claims coming back and forth. So eventually, if we tip the scales enough, I think we'll see more movement on physician comp models, but we're starting to see that. And I think Dr. Gregg would agree with that, having just been on the provider side not that long ago, that the physician comp models have kind of evolved as value-based programs have gained in popularity. Anything you want to add there, Dr. Gregg?
Oh, I think that's right on, case on point. They're really in the provider comp models, there's really just a base salary model where they're not incentivized to do more, and then there is the production model. But then if you throw high quality outcomes to that, then you do see a shift in provider behavior. And the providers aren't going out of their way to do things inappropriate. They just try to do more because they think more is better. And sometimes more is not always better. And you want to apply logic to your testing in your volume. And so this makes you step back and think about, what am I doing this test for? Why am I doing this? Is this really adding value? And I think it's changed the way providers think.
Perfect. Thank you, Dr. Gregg. With that, we've gotten through all the questions that the participants have asked today. I'd like to thank you all for joining us again today. I'd also like to thank Chelsea Matter, Dr. Greg Glasner, Pat Belmore, Mike Carlson, and Chris Kalesa for answering the questions that all of our viewers had today. So With that, we're going to end the webinar, and we look forward to ongoing communication with BlueAlliance as we try to keep everybody in the loop on the benefits of this program. So thank you all again, and have a great afternoon.